And welcome to our live stream of spine surgery. Today we're going to be performing a Deuk laser disc repair on a patient who injured her neck in a car accident. And she has a herniated disc. Shot. 2, 3, 4, 5, 6, 7, T1 at C7-T1. Shot. Let's shot. Get an AP. So the first thing we have to do is get into the disc. Quick AP. That looks not too bad. I could be a little bit more over. Shot. 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 All right, let's get an AP. Looks good on the lateral. Let's just check everything on the front back projection. Shot. That looks perfect. That's really good. All right, so she has a herniated disc at C7-T1. Now normally we cannot get to this type of disc herniation through the front, but in her neck we're able to. Shot. Okay. So now let's count. Go ahead, Jordan. 2, 3, 4, 5, 6, 7, T1. We are at the right disc. We're going to do our discogram. We're fixing one disc today. This C7-T1 disc is a large herniation central. It's compressing the spinal cord. So, shot.
Uh-huh. 5 cc, please. 5 cc syringe, please.
Shot.
Thank you.
I think we got it in. It's in there. I think. I think I got enough. Huh? Before it broke.
1 second.
Well, it's never a good sign when your dye doesn't want to come out. Usually an indication of a lot of scar tissue in the disc. Jordan, I need to see that disc a little better.
Yes, sir. Yes, sir. There we go. Yeah. That's nice. Nice work.
Yeah, that's good. All right, we're going to give a little bit of numbing medicine. So the patient has a herniated disc at C7-T1, and we're performing an endoscopic Deuk laser disc repair. Let's give the medicine a minute to work. We're going through the front. We're going through the disc. 11 blade. I'm going to make a 4 millimeter incision. The whole surgery will be done endoscopically. I've got to check the position of the guide wire. Shot. I need to see that disc a little bit better, Jordan. Shot. All right. Well, let's see. Shot. Looks like the guide wire is in proper position. Shot. Yes. It looks good. I'm bringing out the needle. And we're going to place our dilator down. Dilator will spread the tissues, not harming them. Shot. We're just going to follow the guide wire. Shot. Shot. The thing about herniated disc, shot, is that they're located in the back of the disc. Did I make the incision big enough? Shot? Yeah, I did. Still a tiny incision. We're right on the spine. That's where we want to be. AP. Shot. That's perfect. That's what we want to see. Show us the tip of the dilator relative to the middle of the spine. Now there's the tip of the dilator, there's the middle of the spine. So we're dead center. We are at C7-T1. We're going to go back to a lateral view. And so far we've lost about 4 drops of blood. That's pretty much what we expect to lose for the whole surgery. Just everybody hold right where you are. It looks perfect. I'm taking out my guide wire. I'm going to advance the dilator through the disc to the back where the herniation is. Shot. Almost there. Shot. Almost there. Shot. That's perfect. Now we're going to bring our tubular retractor down and place the tip of this at the back of the disc where the herniation escapes. We're going to use the laser and the grabbers instruments along with the endoscope to find the herniation and to remove the herniation. Thanks. All right, now I need a little inline traction. Luis, I need you to get both shoulders. Let's see what we got. Shot. That's really good. Hold it right there. Shot. Inline, you guys give me inline. We get a little bit more view with the x-ray. Almost done. Oh, that's perfect. I felt it advance. Shot. All right, that's almost perfect. Let me advance my dilator a smidgen. Shot. Yes. Remember, you don't want to do a biopsy of the back of the disc, so you don't want to advance the tube without the dilator being there first. Move back again. So there must be some pressure here. Must be inflammation. Oh, nice. Jordan, what do you got, rabbits up your sleeve, my friend? What? I don't know how I did that. Merry Christmas. Shot? That's perfect. Well, whatever you did, do it again. Right? So we can see perfectly. Very nice. We are now at the back of the C7-T1 disc, right where the herniation escapes and presses out on the spinal cord behind it. We're going to go in there and remove that herniation using our endoscope, laser, and sometimes we bring in the grabbers. We call them grabbers. They're actually a pituitary rongeur. But it's easier to say grabber than pituitary rongeur. Of course, it derived its name from a procedure where we would go into the brain and take pituitary tumors out using these grabbers called pituitary rongeurs. And I was trained by one of the original neurosurgeons who did those types of surgery, Dr. Albert Roten, one of the grandfathers of pituitary surgery. In his esteemed career, he was very well known and recognized worldwide as being an expert at removing pituitary tumors. I trained directly underneath Dr. Roten at the University of Florida in Gainesville. As a matter of fact, Dr. Roten is the reason I went and trained at the University of Florida. He built the program.
Is he retired?
He's dead. He retired and died. Considered by most in neurosurgery to be the greatest neurosurgeon of our generation. Not just a neurosurgeon, but also he built the neurosurgery residency in the University of Florida into one of the top in the world, which is why I went there. At the time I went to neurosurgery, it was number one. All right, we are at the back of the disc, and look at that view. All right, you guys see the tear in the back wall right there? That is a tear in the posterior longitudinal ligament. And there's the herniation right there. You guys see it? Like literally right there, full of scar tissue. So I'm going to try to get out as much of this as I can. That's our objective. For those of you wondering, do you ever get 100% of the herniation? Never. I've never gotten 100% of a herniation in my entire career. It's not possible. Surgeons cannot remove 100%. We can do our best, which is always going to be less than 100%. Even if you took a brain tumor out, you're still going to get less than 100%. One of my attendings, he was a brain tumor surgeon, Dr. Bill Friedman. He made the point, and he was right, that even the best neurosurgeons can only get about 99% of a brain tumor out. You can't get 100. So, what do you have to do? You have to use radiation after you're done to radiate the area that you operated on and try to destroy as much of the tumor cells as possible. If the average brain tumor starts out with, I forgot the number, but I think it's somewhere around 10 to the 9th or 10 to the 11th cells, and you get rid of 99%, then you're still left with a very, very large number of tumor cells, around 10 to the 9th. Of course, we're not taking a tumor out here, we're taking out a herniation. And herniations are, in essence, they are kind of like a tumor in that we have a mass that needs to be debulked. So far, everything's going well for this young lady. How is she doing, doctor? Is she stable? All right. Wonderful. So yes, we will. Thank you. The first patient? I'm getting water on my toes. That's good to hear. We're just talking about the last patient we did surgery on. He's almost ready to go home. He's 81 years old. We fixed 2 discs and his facets, and he's doing really well. No pain. What a birthday present, huh? He's ready to go. This is not an easy disc to remove. There's a lot of scar tissue here, which is surprising. I don't know when her accident was, but I didn't think there would be this much. Do you know when that happened? A year ago. Well, she's had a lot of inflammation here. Tremendous amount of scar tissue for a more recent herniation. So. All right, Sanjay, let's show the audience how is it that a herniated disc can cause so much pain in the neck. Okay, you can see, oh, a big herniation there. Let's get the grabber. You can see that I've been working on removing the bits and pieces of herniation. Look at this piece here. Let's get the light on here quickly. And can you see this, Sanjay? It's big for a cervical, but it's not big, you know, for a lumbar. You guys see that?
Yes, we do.
It's about 5 millimeters, and that was definitely a herniation. So it was the biggest one I've seen in her case. Let's go back in. Now, I've been also using the laser on a scarred up herniation, a piece of herniation that's just scarred right on top of the spinal cord. And we just have to be really careful as we do this. We don't want to injure anything. But look, this is all scar tissue, the white stuff here. And look at how calcified it is. That's the gold color. Everything gold right there is calcified. Meaning the amount of inflammation is so much that the bone is starting to be formed, like almost like fusing itself. This is all related to an injury she had from a car accident. Yeah, right there. And you see how precise the laser is. This is far more precise than any other type of surgery we could do. But it's literally was sitting on top of her spinal cord right there. We've gotten rid of about 70% of it. The part that was pushing on her spinal cord right here. We just have to be really careful here. Yeah. All right. Let's flip around. Any questions?
No questions.
So this is a lot worse than it looked like on the MRI. On the MRI, it looked like a simple herniation. Given her history of car accident a year ago, I thought we'd have just a herniation, not any scar tissue, very minimal. But her body responds to inflammation, with inflammation that's very powerful. Some people are far more, their inflammatory systems are far more aggressive than others. And I'm an example of somebody with a very powerful inflammatory system. Every time I get sick, my inflammatory system takes over and just kicks my butt. And my best friend is anti-inflammatories, like Motrin. Other people, though, have the same illness and they don't have quite the inflammatory response. In her case, she has a massive inflammatory. Look at all this. All the gold is calcium. It only happens with severe inflammation. So there's herniation with calcification and tremendous amount of scar tissue from a severe, robust inflammatory reaction. Any questions?
No questions.
It's just literally so thick scar tissue. Massively thick scar tissue. There's a piece of herniation right there. All right, I have to grab that one. It's too big. It won't come out with the laser. It looks like we freed it up. No. All right. There we go. So far, everything's going well for this patient. She's stable? I just need another couple of minutes and we should be done. Yeah, we didn't get the herniation. It's too big. Let me try to grab it again. I got a little piece of it, but I didn't get enough of it. Wow, I just had to tug on it. It feels like it's pretty big. There's a piece. It's just not coming out. So I'm going to have to use the laser to break it up in a littler pieces.
We have a question from Phil on YouTube.
Phil, sure.
Can calcifications or scar tissue be a result of waiting too long
Yes.
to be treated?
That's exactly what it's a result of. The calcification in scar tissue is a result of waiting too long to be treated. Had this patient, for example, come to us right away when they had the herniation, they wouldn't have any of the calcium or scar tissue. They would have had a soft herniation. We could have sucked it out quickly and been done with it. But oh, there's another good sized chunk. That's another 5 millimeter we just pulled out. 5 by 5. I'm not going to stop the surgery to show you, but you can just rewind if you want to see what it looks like. All right, just about done. Yeah, so the problem is if you leave your herniation there, the body will react to it, and it'll just create more scar tissue. The best way to think about this for most people is to think about pimples. Remember when you were a teenager and you had pimples? Like, remember how some people, unfortunately, they just never dealt with the pimples, and they ended up scarring their whole face, like with those pits? That happens, and that's a result of inflammation just going crazy, related to the pimples, of course. This is the same thing. Instead of bacteria causing the inflammation like you do with pimples, now we have the herniated disc is what causes the inflammation. But it's the same concept. The longer the inflammation's going on, the more severe the inflammation, the more scar tissue and damage that's going to happen at the back of the disc. Now that said, yes, the damage is permanent. I can't undo damage. Nobody can. But we can still get rid of patients' pain with the surgery, even if there's a lot of damage, which is why I tell everybody, don't look at the MRI to figure out how your surgery went. We need to see how your pain is. Did we get rid of your pain? That's really our goal. It's not to make your disc look normal. We will never be able to do that. It's to get rid of your symptoms. And this surgery does that. It's amazing. At least it gets rid of the symptoms that are from the disc. Now, if you have symptoms from other things, if your knee hurts, of course, we're not fixing your knee. Man, there's a lot of herniation back here. Look at all these pieces. Dr. B, it's taken me a little longer. I apologize. But I just have to float each of these out. Wow. This is a herniation right there. Huh? If we're almost done, I need more. I need more time. Yeah, I need about another 5 minutes. This is more than I thought. This is worse than I thought. So, based on the MRI. That's why you can't really rely on the MRI. It just doesn't show you everything. Any questions, Sanjay?
No questions.
Pretty amazing view, huh? At the back of the disc, the epidural space. Just about done.
We have a question from Roscoe on YouTube.
Sure.
What are the dangers of having a ligamentum flavum buckling in the lumbar disc?
I did not hear the entire question. I heard,
What are the dangers of having a ligamentum flavum buckling in the lumbar disc?
What are the dangers of the ligamentum flavum buckling in the lumbar disc? I don't think there are any. I haven't seen that. So, I'm not sure where you're getting your information from, but there is a ligamentum flavum in the lumbar. But I'm not sure exactly what you mean by buckling in the disc. Almost done. Wow, this is a pretty bad disc herniation. Almost done. I just want to clean out the foramen on both sides. I've already done the patient's right side. Now I'm working on the left side.
We have a question from Royal View Tube.
Oh yeah, there it is. That's probably the last herniation right there. That was on the left side. Yes, Brian.
Doc, what are some of the symptoms of C7-T2 causes?
Yeah, what are some of the symptoms that a C7-T1 herniation would cause? Like this: neck pain, headaches, arm weakness, numbness, tingling, and even balance problems if it's affecting the spinal cord. We call that myelopathy. Atrophy if it's bad, atrophy in the hands. Bladder incontinence, urinary incontinence, can't control your bladder, end up peeing on yourself. Well, you can already see the spinal cord appears to be pushing back a little bit, which is good. Man, this is a lot harder than I thought, because the herniations are far more calcified than I expected. That's it. There's a crack right there. You guys see the crack? I mean, literally right there. And there's herniation. We've gotten rid of most of it. We will not get 100%, and don't expect to. Wow. Oh yeah, look at that thing. Like a little serpent going back in its hole. You see that?
Yes, we do.
I don't know. It's very risky here, but I wonder if I can get that thing to come out. And this is why we use this particular laser. See that?
Yes.
So what I'm seeing is the effects of what's called the pressure wave. Okay, I'm blasting it here, it's shaking it out, and then I come here and I get some more. See that? We're really close to having all of it. That is a herniation that's calcified, and it's playing games with me. It's hiding. Oh, here we go. Come on, look how calcified it is. That's the white color. It shouldn't be calcified. We've gotten about 80% of it now. I always preach about don't gild the lily. And I don't want to gild the lily. The problem is I can't see the whole thing. All right. I feel really good about that. By the way, this is the part that is pushing on her spinal cord. So I really want to get as much of it as I can without creating any problem for her. The rest of the herniations are pretty much gone. And I think we are looking good. Wow. Incredible, huh? That's all PLL, posterior longitudinal ligament. There we go. Oh yeah. The beast. Look how calcified it is. Wow. Incredible. Huh? Yeah. You're right. Yeah. There's the spinal cord right there. So we're just literally on top of it. Oh, yes. Look at it come. You see it? It's raging now.
Yes, we do.
I'm fighting the dragon. Huh? I think that's all I can really dare to take out. I think I've gotten 90% of it. There's a nice cavity. It looks decompressed. I just don't want to overdo it. This is one of my worst battles ever. Look at the bone spur there. Wow. Yeah. Yeah, we did it. That's it. Yeah. I can't take any more out safely. This is just stuck down. What's left. And the most important thing is not putting pressure on the spinal cord anymore. We've gotten rid of the pressure. So that's a victory.
Thank you.
Wow. That was a battle. Thank you, everybody. Great job. If you have questions, type them up. We have one more surgery today. It's a single level lumbar. Deuk laser disc repair. Whew. I'm sweating. I am sweating. That was not easy. Let me show you the whole incision. We lost 3 drops of blood, and the whole surgery was done. You guys see this? Through a 4mm cut. Not an easy surgery at all.
Yes, we do.
This is the front of her neck. But it went beautifully. You guys see this? So maybe 5mm. Great job, everyone. And go ahead and type up your questions. In the meantime, Sanjay, why don't you show our audience how the Deuk laser disc repair works?